What brings us here? To this place with the coldest winters and hottest summers? We don't come here to retire. We come here to live, to be challenged, to be inspired. This is a city that demands fresh thinking and duly rewards it. If you can make it here, well, you know what they say. We New Yorkers, we're always pushing ourselves to be better. No wonder this city gives us the best of everything. You don't have to look far to see it. It's all around us. The best food, the best music, the best medical care, the best train station. At NYU Langone, we're collaborating on every level to be the best we can be for New Yorkers and for everyone who seeks our care. After all, we're New Yorkers too.
Hello and welcome back to Women's Health Watch, a show brought to you by NYU Langone Medical Center. I'm your host, Dr. Kosta, cardiologist at the Joan H. Tisch Center for Women's Health at NYU Langone Medical Center, and I will be sharing some very valuable information about your health. Today's topic is cardiology, and my special guest on this episode is Dr. Andrew Cambitsis, who is with the NYU Langone Cardiology Associates, Queens, located in Astoria. Welcome, Dr. Cambitsis.
Thank you.
Welcome to the NYU Langone family, and I noticed that we're both NYU graduates of NYU.
That's correct.
Yes?
That's correct.
So it was a long time ago, blast from the past.
Very long time ago.
And welcome. Tell us a little bit about yourself and about your practice.
Sure. I graduated from New York Medical College, and I did my residency at Long Island Jewish, my medical residency, and I did my cardiology fellowship at Beth Israel Medical Center in Manhattan. I completed that in 1986, and as soon as I completed that, I came straight to Astoria, and I opened up my office in 1986.
So you have a lot of experience. Seen a lot of cases, a lot of patients.
We've seen a lot of cases over those years, sure.
So tell me, today we're going to talk about heart failure, and tell me, how prevalent is heart failure in the United States?
Well, heart failure is a very prevalent condition in this country. Approximately at least 5 million people have been diagnosed with heart failure in the United States. And every year, approximately 500,000 people are newly diagnosed. And it's a big factor in terms of the amount of expense that's involved in treating heart failure, and it's approximately $30 billion that it costs the economy in terms of the treatment, medications, hospitalizations, loss of work. So it is a big problem in the cardiology field.
And how does it affect women? Do women get sicker who have heart failure? Do they have a higher mortality?
Well, I would say that I cannot say that it's a drastic difference between men and women in terms of symptoms. You know, they both develop similar symptoms, such as one of the main symptoms is fatigue, shortness of breath on exertion, some occasional chest heaviness, sometimes palpitations, swelling of the lower extremities. So those are the basic symptoms that are common in both men and women. So it's not a tremendous difference that I've seen between men and women in terms of symptoms. Sometimes the etiology may be a little different.
Okay, so let's tell our viewers, because people hear of heart failure and panic,
right.
Let's define heart failure for our viewers and
right.
what the types of heart failures are,
sure.
The classes of heart failures that they know.
Well, heart failure basically means the inability of the heart to pump blood to supply the various organs of the body with their needs in terms of oxygen and nutrition. And there are different types of heart failure. For example, there's the heart failure where the muscle is weak. That's called systolic heart failure. And there's the heart failure in which the muscle is actually looks strong, but yet again is not able to supply the proper oxygen and nutrients to the various parts of the body. So the main types of heart failure are systolic and diastolic. Systolic means, again, a weak muscle, and diastolic means a strong muscle. But in both situations, the symptoms are usually the same: shortness of breath on exertion, fatigue, a weakness, and an inability to do what you used to do several years prior. For example, you were able to run around, do your shopping, climb the stairs. All of a sudden, you notice that you're not able to do these things.
And with the diastolics, they tend to have stiffer hearts, correct?
Diastolics tend to be a stiffer muscle. And generally, you see that more often in the elderly, particularly females. Hypertensive females, for example, they complain of inability to breathe. They walk around, they have to stop in the street, they have to stop climbing the stairs because they just can't breathe. Sometimes they get admitted to the hospital with congestive heart failure, pulmonary edema, water in their lungs. And you examine them, you do a test on their heart, and you notice that their muscle looks actually very strong. But in these patients, they have a stiff heart muscle. It's not able to relax. And during the relaxation phase of the heart is when the heart fills with blood. And if it cannot relax and it's stiff, it cannot fill properly, and the pressures within the heart are elevated, and they get transmitted back to the lungs, and it causes these symptoms of shortness of breath.
So people hear heart failure and they panic, but there's different stages of heart failure. Some people could be without symptoms, some people could be very symptomatic. So let's tell them, it doesn't necessarily mean a bad thing. You could have stage 1 heart failure. So let's tell them a little bit about different stages.
Well, the different stages are generally 4 main stages. It's the first stage is where the patient is minimally symptomatic, if at all. They're able to do their normal activity. They may have some findings on an ultrasound, on an EKG, but generally they continue to lead normal lives, and they don't have any of the major symptoms of heart failure at that point. But as they get progressively worse, the second, third, and more so the 4th stage, they become more symptomatic, and they start to experience the symptoms I mentioned earlier. Shortness of breath on exertion is one of the main symptoms. Fatigue is another main symptom. Eventually, they may develop swelling of the legs, which is also a very common finding. And eventually, a lot of these symptoms occur generally when they exert themselves. Eventually, in the final stage, they can develop these symptoms even at rest. For example, the shortness of breath doesn't even go away when they rest. They remain slightly short of breath. They can't sleep at night. They may wake up in the middle of the night with shortness of breath. That's called paroxysmal nocturnal dyspnea. They may have orthopnea, which means they cannot lie flat. They need 3 to 4 pillows to keep themselves up, to breathe properly. That is really the final stage in heart failure. And that's when you may have waited too long to have taken care of yourself, and it may be more difficult to treat at that point.
So you touched about how men and women are pretty similar with heart failure. We covered that topic a little bit. We're not that different. We have similar symptoms. Let's talk about how we can help people prevent heart failure. What are some measures patients can take to prevent going beyond stage 1 or heart failure at all?
Well, you have to understand what are some of the causes of heart failure. Mm-hmm. And one of the main causes, for example, are hypertension, which is a main cause. Other causes are coronary artery disease. In other words, the blood flow to the heart doesn't function properly, and the muscle gets damaged. That can lead to heart failure. Valvular heart disease is another main problem for heart failure. People may have developed rheumatic heart disease at a young age, and eventually they may have developed mitral stenosis, or they may have aortic stenosis, and these things can lead to heart failure. Others may have been born with a congenital abnormalities such as a hole in the heart, which causes abnormal blood flow and damage to one side of the heart. It can lead to heart failure. So there are many causes of heart failure. And the most important thing is to get to, if you have a family history, risk factors such as hypertension, diabetes, smoking, anything that can cause coronary artery disease, or any family history for anything significant with respect to the heart, you should follow up with your heart doctor or your internist to determine whether you need to proceed with further tests to find out what exactly could be the problem and how to treat it before it gets worse.
So the earlier the intervention, the better.
Exactly.
And the prognosis is good if you intervene
early. If you intervene early and you take care of the problem, for example, if you have blocked arteries, you want either open up the arteries or have a bypass if necessary to prevent damage to the heart muscle. If you have your cholesterol is elevated, you want to treat it and make sure to keep it down so it doesn't block your arteries. If you have high blood pressure, you must treat it to prevent the heart muscle from getting stiff, enlarged, and weak eventually. So there are different things you have to do to prevent the progression of heart disease.
And monitoring leaky valves. And if you have high blood pressure, your valves leak more. You have to monitor that, progressive leakiness.
Exactly.
So yes. So what do you tell your patients is a good pressure? I tell them 140/80 maximum. I know it's very controversial. What do you tell them?
To be honest with you, I've been telling them pretty much the same thing about 140 maximum systolic, and the low number 80. Sometimes I'll say 85. It's not easy to control blood pressure.
No.
Right. Obviously, you give people medication. You tell them watch your diet. They come back, their blood pressure is still a little high. You try your best. You adjust your medicines. You tell them to watch their diet, but it's still not an easy thing to control. But you got to give them a little leeway, a little, in terms of the number. You can't be strict and say it has to be under 140, it has to be under 180, because sometimes it doesn't work that way.
It does. And about cholesterol, I know now should we have low LDLs, high LDLs, be more permissive with our LDLs? What do you tell your patients? Do you risk stratify them and then decide if their LDL should be very low or if their LDL is okay at 100 or 130? What's your ideal LDL, which is the bad cholesterol? Just
the bad cholesterol, particularly the LDL, is the goal. You want to get it below a certain number. Particularly somebody who has already risk factors and underlying coronary artery disease, you want to get that LDL as low as possible.
So about 70
about
or
70
60?
or less would be ideal. Again, sometimes it's not easy to do.
I agree.
If you can get it to a reasonable level, generally below 100, I think it's acceptable.
And HDL also, we try to get our HDLs up above 50 for women and above 45 for men.
45 for men, that's exactly it.
That's also hard.
But it's, again, not easy to do. I mean, we do have great medicines these days, the statins, for example, that have made a big difference in terms of getting these numbers to the right level, particularly the bad cholesterol, the LDL cholesterol. It's a lot easier to get it down today as compared to many years ago when these drugs weren't available.
And do you treat triglycerides?
That's another controversial area there. You have a lot of people, you treat their cholesterol, you notice that their LDL is below 100, their overall cholesterol is less than 200, but their triglycerides are 300, 250. Now, what do? Do you give them more medicine for that? I generally, if it's in within a reasonable range, if it's like normals, they're generally less than 150. But let's say it's up to 200, 250. I just tell them to watch your diet.
Watch your diet. Fish oils help too.
Exactly.
For some people.
Exactly.
So I've been asked to define cholesterol for patients. So total cholesterol is LDL plus HDL plus 1/5 triglycerides. So we always check. I don't just check the total cholesterol, I check the individual parts, but let's tell them what the individual cholesterols mean, HDL, LDL, triglycerides. Tell us about those.
The total cholesterol we mentioned. The LDL is generally considered the bad cholesterol, which is involved in being deposited in the arteries of the heart or various other arteries. And the good cholesterol is the HDL cholesterol. We try to maintain that as high as possible, which helps clear the arteries of the bad cholesterol.
And the triglycerides are the small fat particles.
It's another fat particle. It's not. Again, it's a little controversial as to what exact role.
But it is amenable to diet and exercise.
It is diet, exactly.
But diabetes control.
That's right.
Control,
a lot of diabetics have high triglycerides.
Yes. So at what age do you tell your women patients and men patients to check their blood pressure and the cholesterol? Do you have an age where you start to monitor?
I think the earlier the better.
I agree.
I mean, for example, again, it depends on the family history too. You like to know what's the family history of the individual. Let's say a 25-year-old comes to my office, and they have a cholesterol of 230. Am I going to rush to put him on statins? A 25-year-old? Probably not. I'm going to ask them to tell them to exercise, watch their diet, and cut out any other risk factors that they may have, such as smoking or excess alcohol use or whatever they may be doing. Now, if I follow them over the years and also they have a strong family history for heart disease, their father had, for example, had premature atherosclerosis, then at some point you may want to treat them for their cholesterol. But generally, I would, a younger crowd, I would observe and watch them for a period of time.
But you start checking at any age?
At any age.
No cutoff?
No, not necessarily.
And particularly if there's a family history, you'll start younger.
History, you would.
Even a 30-year-old, 25-year-old, you would check.
That's right, exactly.
Yes. So the other question I have is, what do you, when you advise about diet, what are some healthy meals people can eat to lower cholesterol? I mean, the Mediterranean diet, for instance, but what components of that are really good for the heart?
Well, the Mediterranean diet, I would say fish, olive oil.
Olive oil is great, you're right.
Virgin olive oil, supposedly. That's the vegetables, fruits. Supposedly that's all part of the Mediterranean diet.
Everything our ancestors ate in Greece.
That's right. However, the problem is, we may have that type of a diet as Greeks, but unfortunately we counteract that diet by other bad habits, such as smoking, not checking our blood pressure regularly, not taking our medicines regularly. There are other things, or drinking excessively. There's other things that will go against the Mediterranean diet, the benefits of the Mediterranean diet.
It's more than just diet.
It's more than diet. It's just diet, exactly.
Okay. So now we're going to hear from our community on how aware women are about their cardiovascular health.
Maybe once every 6 months.
Not often. Once a year when I see my doctor, she checks it.
4 times a year.
I check my blood pressure whenever I go to the doctor, probably 2-3 times a year. I think it's good because working a lot and you don't know, sometimes you feel dizzy, sometimes you feel fine, but your blood pressure can be high and you should check it often.
117/70.
I think it's 110/80.
It's bad. It's over 100 or actually over 200, so it's bad.
I don't know my cholesterol now, but I think I went to the doctor last month and he said my cholesterol is perfect, so I don't know what it is, I don't remember, but I think it was good.
I don't know what my levels are. They do a blood test every year, and so far it's been normal, so I don't bother with it.
Yes. I'm on blood pressure medication.
Yeah, absolutely. It's important to check your blood pressure so that you can manage if you have hypertension, high blood pressure, low blood pressure. Those things need medical attention, so it's important.
And welcome back. That was very interesting. Some people didn't know their numbers. Some people never went to the doctor. Some people didn't know what their blood pressure was, even after they went to the doctor, or cholesterol. What do you think of that? What could we do to raise awareness?
Well, today there's so much information out there on heart disease, heart failure, medications for heart failure. And I think the internet has made a big difference in terms of the people becoming knowledgeable with respect to their symptoms, their disease, their progression of their disease. So I think there's a lot out there for people to go onto their internet site and go to various websites where it helps you learn a little bit more about the medications that are used, the treatments that are available for heart failure. And it's also important that they discuss with their doctor when they're there, when they do visit the doctor, that they discuss to have the doctor explain to them fully what is exactly their blood pressure, whether it's in the proper range, have the doctor describe to them the medications they take, what role they play in treating their disease process, and how those medicines will help them eventually prevent them from getting worse. So I think it's a lot of it has to do with the patient becoming a little more aggressive with respect to the doctor and becoming more knowledgeable with respect to getting on the internet and learning about their disease process.
So basically people should go to their doctor, know their numbers, and discuss this with their doctors and know why they're taking certain medications. Exactly. This way they also understand why it's important to continue them. Right. And then some people think that you take a blood pressure pill for a couple of weeks and you've cured your hypertension, your high blood pressure, when in fact you don't cure it, you just treat it for life. You can decrease the amount of medication you take with better lifestyle, but you're probably likely to be on it for life.
Yes, most people have to realize that when you're being treated for high blood pressure or heart failure, or ischemic heart disease, it's not a 2-week treatment, a month treatment, it's a lifelong treatment. And they have to become accustomed to that. And a lot of patients come to me after I started them on a statin, for example, for their cholesterol. And all of a sudden they'll come back and say, wow, my cholesterol is below 200, that's great. Now I can stop the medicine. And I say, no, you can't stop the medicine, you know. This is something you have to continue, along with your diet and other risk modifications.
But the good news is you have a better quality of life if you can control your disease with medication. I mean, 40 years ago, people didn't have these options. They died sooner, right?
Exactly.
So we'll be going to a commercial break. We're going to cut to a quick commercial break, and when we return, more great information on how you can keep your heart in good shape.
More than 8 million people live right here. 27,000 of us for every square mile. That's a lot of people. What makes this city such an attraction? What makes this place so cool? We take pride in saying, I'm a New Yorker. And that's the way it's always been. One thing we've all learned in recent times is that no matter what life throws at us, we face it together. And we always come through, stronger than before. We are, for the most part, good people. We come to the aid of others, willing to lend a helping hand because we care. Even though we sometimes get the impression we don't. At NYU Langone, we're here to care for our fellow New Yorkers and for everyone who needs us. That's what we do. That's what we love to do. What brings us here? To this place with the coldest winters and hottest summers? We don't come here to retire. We come here to live, to be challenged, to be inspired. This is a city that demands fresh thinking and duly rewards it. If you can make it here, well, you know what they say. We New Yorkers, we're always pushing ourselves to be better. No wonder this city gives us the best of everything. You don't have to look far to see it. It's all around us. The best food, the best music, the best medical care, the best train station. At NYU Langone, we're collaborating on every level to be the best we can be for New Yorkers and for everyone who seeks our care. After all, we're New Yorkers too.
Welcome back to Women's Health Watch. For those of you just tuning in, today's topic is cardiovascular health, and joining us is Dr. Andrew Cambitsis. Before the commercial break, we spoke about heart failure, risk factors, definition of heart failure, and now we're going to talk about how you diagnose it. So what are some ways to diagnose heart failure?
Okay. Well, for example, when a patient comes to my office with some symptoms suggestive of heart failure, such as they complain of shortness of breath, I'm tired, I can't climb up the stairs anymore as I used to, I can't do the work around the house as I used to, I've noticed some swelling of my feet, I generally will start with obviously the physical examination, check their blood pressure, see is their blood pressure very high, is it low. I will listen to their lungs. Do I hear anything to suggest water in their lungs, which would indicate heart failure? I will listen to the heart sounds. There are certain sounds that you can hear, such as murmurs or extra heart sounds, which could suggest heart failure. I would check their ankles to see how much swelling there is, if any. That's part of the first step towards diagnosing heart failure. Then after that, I would proceed with a basic heart test, such as an electrocardiogram. I would do an EKG. Sometimes an EKG can indicate damage to the heart muscle, such as prior heart attack. It would indicate that, which may suggest a weak heart muscle and, as a result, heart failure. I would then, after that, do other tests, such as an ultrasound of the heart, which is one of the main tests in terms of diagnosing heart failure. That's basically the sound waves that are passed through the heart, and you get images on a TV screen, which actually shows the heart muscle and the size of the heart and how it's contracting, whether, as we mentioned earlier, there are two types of heart failure, systolic or a weak heart muscle, and there's the diastolic heart failure or the normal heart muscle. And a systolic heart failure, generally we assign a number to that, which gives us an indication of what the strength of the heart is, and that's the ejection fraction. So if somebody comes into my office and I do an ultrasound, and I see the heart's enlarged, and it's not contracting as it should, it's contracting weakly, I can estimate what the ejection fraction is.
So what's a normal ejection fraction?
A normal ejection fraction is generally anywhere from 50% to 70%. That's a normal, it's a range.
Because the heart never completely empties.
It does not,
empties
no.
50 to 70%. So that's a
Exactly.
normal ejection fraction.
That's a normal ejection fraction. Now, as we said, now somebody who develops systolic heart failure or a weak heart muscle, I will notice on the ultrasound that the ejection fraction, I can estimate it by looking at it, that it will be probably less than 50%, generally less than 45%, such as often you see ejection fractions in the 40s and often in the 30s, 35%, and even sometimes down into the 20s. I've seen it as low as 15% sometimes. You know, that's pretty much at the end stage heart failure. And then also you have another, on the other hand, a patient may come to the office with similar symptoms, and I will do an ultrasound, and I will notice that their muscle is actually not weak. It looks pretty strong. But yet they still have heart failure or symptoms such as the other patient with the weak heart muscle.
So that's the normal ejection
And that's a
fraction
normal
heart failure.
ejection heart failure.
That's the stiff heart.
That's the stiff heart. The muscle is contracting, but it's not relaxing properly. And that's as often you see in people that have had hypertension, long-standing hypertension, in elderly females. They may come in with these symptoms of heart failure, but yet their muscle is contracting, but it's not relaxing properly. And that diagnosis could also be made from an echocardiogram, particularly when you do what's called the Doppler of the heart. You can determine that that's what they have, diastolic heart failure.
So we'll start with the physical exam, an EKG, an echocardiogram to look at the ejection fraction and wall motion. And then if people feel bad, if they're short of breath and don't feel good, there are ways to make them feel better. There are treatments for heart failure. So what are some treatments that people should be aware of for heart failure? Okay,
first you would like to try to figure out what is the underlying cause for their problem. Is it a circulation problem to the heart? Is it high blood pressure? And then you would give the appropriate treatment. For example, if it's high blood pressure, you would start to treat their blood pressure with medications, such as you would use what are called diuretics, water pills, to
and that gets
decrease
rid of
the extra fluid from the body that accumulates. You would use what are called ACE inhibitors, such as enalapril, lisinopril. These types of medications are called ACE inhibitors. They also help the heart get out of heart failure. They also improve the function of the heart, and will also lower the blood pressure, particularly if you have high blood pressure. I would then prescribe what are called beta blockers, such as metoprolol, Coreg. There are different types of beta blockers out there that are used also for treatment of heart failure, that improves survival, that improves symptoms in patients with heart failure. But again, it's also important to figure out what is the underlying cause of the heart failure.
And like you said, coronary disease is a big cause, hypertension is a big cause.
Hypertensive heart disease.
There's some other causes, alcoholism.
Alcoholism is also a big cause.
Was a big cause of hypertension.
Right.
Arrhythmias, untreated atrial fibrillation can give you a cardiomyopathy
Long-standing
from a fast heart.
untreated atrial fibrillation with a rapid ventricular, with the heart's beating rapidly, regularly over a period of time, can eventually become weak.
So that's another cause. Rheumatic heart disease, valvular disease.
Valvular heart
if you
disease
have
is
a
another
very
cause.
leaky
That's
valve
correct.
and people don't treat it, that
That's
can
right.
dilate your heart, make it bigger.
That's correct.
So those are some unusual causes of
That's right.
heart failure. But alcohol, people don't realize
That's a big thing.
you
You're
can
right.
have that holiday heart. You binge on the
That's
weekend
right.
and you have heart failure on Monday.
I've seen people with that are heavy drinkers that develop heart failure. Their muscle becomes enlarged and weak. And as I said, sometimes I'm thinking the ejection fraction is low as in the 20s. And believe it or not, I've seen them, if they stop drinking and they take care of themselves, I've seen some significant improvement in these patients. Their ejection fractions have improved over a period of time if they take away that toxin, the alcohol that's affecting the heart.
It's true. And then there's some other ones, viral
Viral is another.
cardiomyopathy.
Well, the viral is a more, it's a more,
It can reverse, hopefully.
it could reverse too, but it could be more damaging to the heart sometimes.
Could be another reason to get a flu shot.
That's correct.
For the reason. So
That's
viral,
correct.
and sometimes postpartum, some women get a cardiomyopathy and heart
right.
failure. So
That's
there
correct.
are some other strange causes, unusual causes. Okay, so we have some treatment. We could do ACE inhibitors, and if some people, 10% can get that dry cough, and in that case, they can use the cousins, the angiotensin receptor blockers, such as
losartan or Kosar.
There's so many now, I can't remember the names.
That's right.
Avapro, Diavan.
Diavan, that's correct. There's all these other medicines that are available, particularly if you develop side effects to Vasotec and lisinopril, which is a cough is a very common symptom.
And you can do 25 other ARBs. There's one on the market every week.
That's right, that's correct.
So some people have very advanced heart failure. They could have an ejection fraction, you said, below 35%. And one of the treatments people have heard about was the one that Dick Cheney got, the defibrillator.
That's correct.
So let's tell patients what that is so they're aware of that. 'Cause sometimes either they will get it or their family members can get it.
The defibrillator is a device, it's almost like a pacemaker type of device. That wire goes into the heart, and there's a little box, a generator that's under the skin. And the purpose of that is particularly for people with the low ejection fractions, people that have severe damage to the heart muscle, because they are more prone to developing severe arrhythmias of the heart, life-threatening arrhythmias.
And sudden cardiac death.
And sudden cardiac death. So the defibrillator is there to prevent that from or if it does occur, it shocks the heart and it brings it back into a normal rhythm. That's the purpose of that. Now, there's another type of defibrillator that may also help to improve symptoms to some extent. That's called a biventricular defibrillator. And that you would put into people that have a weak heart muscle and some sort of generally an intraventricular conduction defect, something abnormality in the EKG, an electrical problem. That's where the ventricles, the two main chambers of the heart, do not function as they should together. They don't beat together as they should. They beat in different times.
So synchronizes them.
So you need to synchronize and put them back to function together to help the heart pump better. And that's a biventricular defibrillator, and that has made a significant improvement in some people's lives.
It has. I know we're getting a little technical for people, but it's information for them to know because they may have...
Well, these are the more advanced treatments in the more serious situations.
And people should know to ask for them if they have heart failure and they haven't been offered treatments like that. So the other thing they could do is diet. Diet's very important in heart failure.
It's always important.
Right. So we tell our patients don't eat salt. What else do we tell them? How much salt can they have?
Well, you try to keep it as minimal as possible. In the hospital, we always recommend a 2-gram sodium diet.
2 grams is not a lot, right? A soda has...
That's right, but you try to keep it as minimal as possible. And of course, not to drink excessive amount of fluids. I mean, people are taking their water pills, and on the other hand, they're drinking an excessive amount of fluid. It kind of one contradicts the other. So you kind of try to prevent you try to minimize the amount of fluid intake and salt intake.
Salt intake is important, yes.
That's very important.
And then it's interesting, I have some patients who have very low ejection fractions, and I could put them on the treadmill and they can exercise, they have a good exercise capacity, and others can't walk to the bathroom. And they have the exact same ejection fraction. I think for them, some of these patients have done heart failure exercise treatments. They've gone to cardiac rehab and they've exercised.
That's correct.
And you could have a low ejection fraction, but with exercise, increase your functional capacity.
It always helps, particularly if you're not that symptomatic. If you can tolerate the exercise, I would advise if they can do a walking exercise, particularly even out in the streets or on a treadmill, but not at a point where they get short of breath and they get sweaty, diaphoretic. I would try to keep it at a minimal level, particularly patients that have low ejection fractions. You don't want them, I kind of discourage them from doing any excessive exercise because it puts them also at an increased risk of developing complications, arrhythmias.
So exercise as tolerated.
As tolerated,
Don't push
exactly.
yourself, but do it every day if you can.
If you can, to the point where you feel comfortable. If you don't feel comfortable, you don't do it.
Okay, so now we're going to go to a commercial break and we'll be back in just a few minutes.
What brings us here? To this place with the coldest winters and hottest summers? We don't come here to retire. We come here to live, to be challenged, to be inspired. This is a city that demands fresh thinking and duly rewards it. If you can make it here, well, you know what they say. We New Yorkers, we're always pushing ourselves to be better. No wonder this city gives us the best of everything. You don't have to look far to see it. It's all around us. The best food, the best music, the best medical care, the best train station. At NYU Langone, we're collaborating on every level to be the best we can be for New Yorkers and for everyone who seeks our care. After all, we're New Yorkers too. More than 8 million people live right here. 27,000 of us for every square mile. That's a lot of people. What makes this city such an attraction? What makes this place so cool? We take pride in saying, I'm a New Yorker. And that's the way it's always been. One thing we've all learned in recent times is that no matter what life throws at us, we face it together. And we always come through, stronger than before. We are, for the most part, good people. We come to the aid of others, willing to lend a helping hand because we care. Even though we sometimes get the impression we don't. At NYU Langone, we're here to care for our fellow New Yorkers and for everyone who needs us. That's what we do. That's what we love to do.
Welcome back to Women's Health Watch, a show brought to you by NYU Langone Medical Center. We're back with Dr. Cambitsis talking about heart failure. And I wanted to mention for the patients who are very, very ill and need advanced treatments, there is a heart failure center at NYU Langone on 34th Street and First Avenue where they have more advanced treatments such as left ventricular assist devices and more advanced treatment basically for the very ill. So that's much more specialized, and I usually don't treat those patients, I send them there. So for those who are very ill, there is other treatment and hope. I wanted to let people know that.
And we should mention the left ventricular assist devices or devices that do the pumping for the heart, basically.
The temporary artificial hearts, in a way.
And it's connected to some battery structure that you carry around with you. And some people use that for long-term survival too sometimes, you know.
Yeah. So there is hope and there is treatment for people, as long as they know where to go and what to do. And now we're going to answer some questions for our viewers. Let's see what people want to know from our reporter, Petros Kasfikis.
I would like to know, I'd like their perspective on how obesity affects cardiac health, especially, you know, there are overweight people like myself that work out regularly. And so I'd like to know, you know, is their risk still elevated, or, you know, what amount of exercise helps cancel out the risk of being overweight or obese?
What you should eat to keep your blood pressure down if you have a problem. If your blood pressure is too low, I want to know, like, how would you know what you should do if your blood pressure is too low? Because I had that problem before, so that's what I'll ask.
What age should I start checking my cholesterol? And what causes high cholesterol?
So I'll let you take the question about exercise. I know we're supposed to put 10,000 steps a day and work out 30 minutes a day for 5 days a week. And what are your feelings on exercise and negating being overweight?
Weight loss obviously is a major factor in preventing progression of heart disease, such as heart failure or atherosclerosis, blocked arteries, things like that. So exercise, doing even a few minutes a day, would be helpful in terms of reversing some of the problems that occur with heart disease, such as correcting the blood pressure, lowering your cholesterol, decreasing the work the heart has to do when you're obese, for example. So exercise is a must for most people.
So the American Heart Association wants us to do 30 minutes 5 days a week minimum. They say the more the better, but if we could do that minimum, that would be great.
Do the minimum, that's important.
And people can get a Fitbit or a Jawbone or a pedometer on their iPhones and do their 10,000 steps a day if they can. Right. That would be helpful too. So, and you could be a little overweight and still healthy if you exercise versus being thin and not exercising. There's a balance there. Exercise is important. And for lowering your blood pressure with diet, there's the DASH diet, DASH. People could look that up on the internet. And in a nutshell, it tells you to eat 3 fruits, 5 vegetables a day because there's natural diuretics in fruits and vegetables.
That's correct.
So that's one way to lower your blood pressure from diet, is the DASH diet. It's a blood pressure lowering diet, not a weight loss diet. But I suppose if you're eating more healthy, you'll lose weight too.
Again, if you eat healthier, such as fruits, vegetables, we mentioned trying to stay away from red meats as possible. Cut down your meat intake as
Which
much as
includes
possible.
pork too, right?
Pork, and
Cows.
stick to the, the vegetables, the fish, poultry more so than meats. Then I think that would be beneficial for preventing the progression of coronary artery disease, along with exercise. That's also important. As we mentioned, the minimum amount of exercise being at least 30 minutes several times a week.
And one of our viewers asked, what raises my LDL? What causes my cholesterol to be high? And that would be...
Well, I think several things. For example, a sedentary lifestyle may contribute to it to some extent. More so, genetics. Family
yes.
history is very important. Very important.
Diet.
The diet is extremely important too. Obviously, as we mentioned, different types of diets. That's important to try to stick to the DASH or the Mediterranean diet.
No fast food. Don't fry your meat.
Oh, I know. That's a big problem in the society with all these fast food stores all over the place. And our lifestyle today is being rush here, rush there, get a bite, quick bite here, get a quick bite there. It kind of throws a lot of people off what diet they should be on.
It's so easy to grab
It's easy to grab
oily
a quick-
Chinese meal or a
That's
burger,
correct.
and your cholesterol will go up.
That's correct.
Will go up. Anyway, and there was one young lady who, this has nothing to do with heart failure, but and we get this question frequently, she said her blood pressure tends to run low. And what do we tell young women like that who tend to run low blood pressures?
Often I see a young woman with low blood pressures, normally.
Yeah.
I see systolics as low as 90, which, and then generally they're asymptomatic, that's their blood pressure. I generally don't treat low blood pressure. How do you treat low blood pressure?
Right. Well, just if it's very hot, we tell them to stay well hydrated. And
Right,
if they
you
sweat,
drink the proper amount of fluids, of course. But generally, a lot of, particularly young females, they have low blood, they walk around with low blood pressure. That's their normal blood pressure. And as I said, they're generally not symptomatic for the blood pressure.
Right, and if you feel good, great.
And
You're
you feel,
lucky.
exactly.
Yeah. So in summary, what do we tell patients with heart failure? How can they live a normal life? What can they do?
Well, basically what I tell my heart failure patients is to make sure they follow up on a regular basis with the physician, make sure they take their medications properly on a daily basis as prescribed. Sometimes patients don't take them as prescribed. Make sure that they watch their diet and don't take excessive amount of salt and fluids, particularly if they have symptomatic heart failure or advanced heart failure. Make sure that they do their appropriate exercise that's tolerated, or they're walking as much as possible, as long as they can tolerate it. All these things will contribute to an overall better lifestyle and probably a longer survival.
And sometimes if patients are very ill, I tell them to weigh themselves daily just to make sure they're not retaining fluid. Because if they go up 2 pounds in one day, they know they're retaining fluid and they should call and adjust their medications. So Dr. Cambitsis, where can patients find you? Where are you located?
I'm located at 22-41 33rd Street in Astoria. That's between Ditmars and 23rd Avenue. I'm exactly right across the street from St. Catherine's Church.
Across St. Catherine's Church.
St. Catherine's Church.
That's terrific.
A very popular church in Astoria.
Yes. Even I know where that is.
That's right.
Yes, okay. Anyway, and I'd like to viewers to know that you can find me at the Joan H. Tisch Center for Women's Health on 84th Street and 3rd Avenue in Manhattan. We are 70% women and 30% men, so multi-specialty practice. You can come for cardiology, internal medicine, dermatology, gastroenterology, endocrinology. It's a lovely practice, and we welcome Greeks and people who have Greek friends. Dr. Cambitsis, thank you for joining us. It was wonderful having you. I hope to see you soon. And that's all we have time for today on our show. Please join us again next week on Women's Health Launch. I'm your host, Dr. Eva Kosta. I look forward to bringing you more information on women's health next week. Same time, same place on Greek TV.
people live right here. 27,000 of us for every square mile. That's a lot of people. What makes this city such an attraction? What makes this place so cool? We take pride in saying, I'm a New Yorker, and that's the way it's always been. One thing we've all learned in recent times is that no matter what life throws at us, we face it together, and we always come through, stronger than before. We are, for the most part, good people. We come to the aid of others, willing to lend a helping hand because we care. Even though we sometimes give the impression we don't. At NYU Langone, we're here to care for our fellow New Yorkers and for everyone who needs us. That's what we do. That's what we love to do.